Welcome to the regular meeting of the Public Health and Safety Committee for June 21st, 2023. I am Latricia Vita, and I'm the chair of this committee. At this time, I will ask the clerk to call the roll so we can verify a quorum for this meeting.
Councilmember Wansley.
Present.
Rainville.
Present.
Ellison is absent. Palmisano.
Present.
Vice Chair Payne.
Present.
Chair Vita.
Present.
There are 5 members present.
Let the record reflect that we do have a quorum. With that, the agenda for today's meeting is before us. There are 7 items on today's consent agenda. Item 1 is authorizing the police department to enter into an ongoing mutual aid contract with the FBI, Bloomington Police Department Bomb Squad, Crow Wing County Sheriff's Department Regional Bomb Squad, and St. Paul Police Department Bomb Squad for assistance in an emergency. Item 2 is accepting a grant from the Minnesota Division of Homeland Security to enhance emergency management capabilities. Item 3 is authorizing the extension of the grant agreement with the Minnesota Division of Homeland Security for 6 months to allow the completion of a multi-year training plan for Public Works water treatment. Item 4 is authorizing the submittal of a grant application to the Department of Energy for the Energy Efficiency and Conservation Block Grant Program. Item 5 is accepting a grant from the Environmental Protection Agency for enhanced air monitoring in communities. Item 6 is accepting a grant from the Minnesota Department of Health to provide culturally specific family home visiting services. Item 7 is authorizing a payment of sponsorship for city presence and outreach at community events for Juneteenth and Somali Week celebrations. Are there any discussions on these items? Councilmember Wansley.
Thank you, Chair Vita. I don't know if staff is present, but I just had some clarifying questions on item 1 and item 2.
I'm trying to see if we have staff here. Oh, here we are. Can you please come up? Thank you. Will you introduce yourself, and then we'll get Councilmember Wansley's questions.
Good afternoon, council members. My name is Kate McKay. I'm with the Office of Emergency Management, and I could speak to item 2.
Okay. You have questions on item 2?
Yes, awesome. Thank you, Kate. I'm just wanting to make sure that the grant funding that's listed in item 2, that's only going towards emergency management exercises for our water treatments, just solely that?
Thank you, Councilmember Vita and Councilmember Wansley, for the question. The overall grant supports primarily the Emergency Management Department, but the extension is so that we can complete the project related to the water treatment multi-year training and exercise program.
Gotcha. Okay. Straightforward question on one. Thank you so much, Kate. The first one, and I can follow up with someone from public health, but just wanted to make sure that the bomb threat will only be activated for the emergencies listed in the RCA, not for other types of emergency situations. So just wanted to make sure I could get that clarified from staff.
Absolutely. We'll make sure that staff reaches out. I don't see Robin McPherson here, who's answered those questions in agenda setting, so we'll make sure she connects. Thank you, Councilmember Wansley.
Thank you.
Is there, Councilmember Palmisano.
Thank you, Madam Chair. I have a question about item number 7, which is an NCR question, and I believe Nick Nago is here and might be able to answer them off the top of his head.
Good afternoon, Chair Vita, Councilmember Palmisano, Nick Mill with Neighborhood and Community Relations.
Thank you. Chair Vita and Mr. Nago, I'm curious, how do we choose where we seek NCR presence at community events, and what do we anticipate getting out of our presence at them?
Sure. So this is actually work that's on behalf of the city, recognizing that the entire calendar year has a whole host of community events. NCR staff selects a handful that knows that are culturally relevant or that are impacting underrepresented communities and particular neighborhoods as well. So the few that we do select don't represent the entire body of work that other city departments do in terms of being present for outreach or community engagement programs. So for these ones, these are large community events, and we work with other city departments to be there and present, such as 311, Civil Rights, Reg Services, and Health. And usually we also look at the calendar years in terms of what particular projects or initiatives are on the docket for the city as well, and just to make sure that we could coordinate a level of presence to be there to do that outreach as well. So it varies across the board, yeah.
So, Madam Chair, what I'm hearing is that generally speaking, we are helping out and facilitating education for things like animal control and 311 and road services.
Yes.
So that NCR is kind of the bridge. We're not there to table about NCR.
Nope.
It's actually helping residents in our communities to connect with different city services or things they might need.
Chair Vita to Councilmember Palmisano, that's correct. We work to kind of facilitate a space, a city presence, recognizing that for some events, there are city departments that are already there as well, but they're kind of scattered across the event or particular area. So we're just trying to consolidate them under a city tent or city presence. Yeah.
I see. It struck me as strange, Madam Chair, that we pay the park board as a sponsor, and because we have different relationships like that, and we're very familiar with Kajug. We're a funding partner of Kajug in many different ways. So thank you for
Yeah.
availing yourself for the question.
Yep, no problem.
Thank you. Well, I just want to note that Councilmember Ellison has joined us. Welcome. Is there any further discussion? Seeing none, I will move for approval of the consent agenda. All those in favor, please say aye. Aye. Opposed, nay. That carries, and the consent agenda is approved. The next item is continuing the presentation from the previous Public Health and Safety meeting on the response to the opioid epidemic. Here to kick off the presentation is Deputy Commissioner Heidi Ritchie. Welcome, and thank you for joining us again.
Thank you, Councilmember Vita, members of the committee, and thanks for having me and the rest of the opioid response team, along with Dr. D, who you became familiar with at our last presentation. Thank you for allowing us to come back and finish and then provide opportunity to answer any of your questions. I'll just start off by a little bit of a review. We won't go through the slides that I've already covered, but I will review some of them. First, I want to just ground us in what this legislative directive says. It's directing the health department to explore pathways for supporting a medication-assisted therapy facility and report back with options and recommendations to the Public Health and Safety Committee. I also just want to restate our statement of a problem because I think it just underscores and also grounds us in what we're actually trying to solve for here. The rate of fatal opioid overdoses has increased by 130% in Minneapolis between 2017 and 2021. In 2021, the rate of fatal overdoses in Minneapolis was 4.6 per 10,000 residents. Rate for opioid deaths among American Indian residents was 82.3 per 10,000, and among Black residents, 10.9 per 10,000 in 2021. This was 29.4 and 3.9 times higher than the rate among white residents, respectively. Inpatient and outpatient visits of Minneapolis residents due to non-fatal opioid overdoses increased by 20% between 2019 and 2021. You can see this is illustrated in graph form on this next page. I'm going to go ahead and skip over the definitions. If you'd like to review those, they're part of the presentation. So at any time, you can review those definitions that I read out at the last presentation. I'm also going to skip over the legal landscape. I think we are aware, and City Attorney Bert Osborne helped us understand that right now on the federal level, this is prohibited, but there are some movements at the state level that we are monitoring. Okay, I'm gonna turn it over now to Dr. D to finish the bulk of his presentation. As a reminder, Dr. Diziwe Nataba is an academic emergency physician with over 20 years of experience working in large urban teaching hospitals and responding to several public health emergencies. He's currently completing a Bush Fellowship with a focus on improving outcomes and reducing local disparities in opioid use disorder. And he comes to us with a Master's of Public Health from Harvard and from Oregon Health and Science University, a Doctor of Medicine. So welcome, Dr. D.
Thank you. Welcome, Dr. D. Thanks for joining us again. Your presentation was just getting exciting at the last meeting, so thank you for coming back and proceed.
Thank you, Chair, for inviting me back, members. Again, it's really an honor to participate in this process. I always like to start these conversations with the framing of the biological basis of disease. And I just noticed that the last slide we left off on is also a brain slide, so maybe we can forward to, I think it's slide 16. That one. From the patient perspective, it's helpful for me to understand this biological basis, understanding this is a medical disease with changes in brain chemistry, changes in brain anatomy at the molecular level. I think that understanding also applies to some of the that root cause also applies to some of the downstream consequences that we see in terms of behaviors and perhaps in terms of effects on communities and society more broadly. So just to review, normal brains have expected levels of hormones like endorphin and dopamine. Those levels change with exposure to these potent opioids, fentanyl more so than others that we've seen previously. Heroin, prescription narcotics aren't nearly as potent as fentanyl, so the effects of the change, the highs are higher, the lows are lower. That withdrawal syndrome is more pronounced, and the patient's aversion to that withdrawal syndrome is also more significant. So the benefits of starting treatment in patients like these, starting the medications that we talked about, I'll be focusing on buprenorphine here. Sometimes I might use the brand name Suboxone, but I don't have any conflicts of interest financially with the company. It's just a more commonly used term. So if I use buprenorphine and Suboxone, those will be interchangeable, referring to medication for addiction treatment or MAT. I've gone ahead and highlighted some of the references to treatment and medication. So when you see yellow highlights, that's an indication of reference to this medication. When we talk about the benefits of starting patients on opioids, I believe we talked a little bit about the reduction in overdose, and we see that across the board. Other benefits of treatment include related harms beyond overdose. We see decreases in infectious disease, hepatitis, HIV. We see reductions in violent crime, and we see improved treatment outcomes overall, improved health and well-being. Next slide. Thanks. Perhaps the best example I can think of in terms of the impact, kind of the gold standard impact measure of medications, is decreased mortality. This slide shows two examples of, on the top, country-level interventions promoting or incentivizing use of medication. The bottom half of the slide looks at Baltimore. So just a little bit of background. In the early 90s, France had a bad heroin overdose epidemic. Their rates were increasing in terms of deaths and all related harms year after year. And then sometime in the mid-90s, 95, 96, they introduced buprenorphine, this medication, to the formulary. Unlike the US, they didn't have any restrictions on who could prescribe this as long as you were a credentialed doctor. They didn't have any limitations on who could access it. It was incentivized and decreased barriers. And just as a result of that intervention, they were able to reduce the rate of overdose deaths by 80% within just 4 years. As far as I'm aware, that's the most successful example of a policy intervention to the opioid epidemic. So just to walk through this graph here, the red lines are heroin overdose deaths. France in the 90s was around 325 per year. That's roughly in the ballpark of what we're seeing in Hennepin County and Minneapolis. The green dotted lines are number of patients started on buprenorphine. And you can see what we call a direct correlation or a mirror image of increasing numbers of patients started on medication and decreasing overdose deaths in red. They landed on the far right of the screen, 85,000 patients started on buprenorphine. They were at a much higher rate with incentives and the lack of barriers and regulatory burden. And I think that helps explain why they were able to have an inflection, not only flatten their curve of increasing deaths, but invert it towards 80% reduction so quickly. In Baltimore, in the early 2000s, they had a similar incentivization, working in collaboration with Johns Hopkins, so they had great public health support, world-class academic support. They were able to also see a reduction in overdose deaths, again, directly correlated with the increasing number of patients started on buprenorphine. But you can see the green dotted line is slower to increase, and it lands at a lower level, 7,500 patients compared to France, close to 90,000 patients. And even though they were seeing a similar pattern in reduction of overdose deaths, the time frame to see that inflection point was more like 5 years rather than just a couple of years in France. So I think it's an important relationship, and as far as I'm aware, this is probably some of the best public health evidence of the importance of this medication. Next slide. Another way of looking at this in terms of benefits of medication, this graph was conducted in, or data compiled from the state of California over a 5-year period, and it basically reflects the survivability of opioid use disorder with or without medications. And the way they frame this data, the top gray bar is what we call the standardized rate of death in the general population in California, standardized to 1 in this instance for comparison purposes. The middle blue line is the observed rate of death for patients with opioid use disorder, but without medications like buprenorphine. And you can see there's a 6-fold increase in the risk of death, or the observed rate of death in that subgroup of the California population compared to everyone else. And then the pink line on the bottom are a subgroup of that OUD population who are started on medication. And you can see that improves the survivability of this group by close to 70-80%, all attributable to this medication. Next slide. Another way of looking at this, because I think it's so important, Portland, Oregon had an analysis done in 2018, I believe, where they looked at a Medicaid population in a tri-metro area around Portland, Oregon, and they looked at the rate of utilization or the rate of needing to go into the ER or be hospitalized in the ICU or the general floors. And then they compared what's that utilization of the health services for OUD patients who are either on treatment or not on treatment. So on the far left, you can see patients who are not on treatment have the highest level of utilization. That's a pattern seen across the country, but in this analysis, this is Oregon. So the upper kind of salmon color is ER visits. The lower red bar is hospital stays. That's on the very left, highest bar. On the very right of the graph represents patients who are started and maintained on MAT for 6 months or more. And you can see a profound decrease in the rate of hospital and ER utilization based on patients being on medication. The other thing about this graph is I think we can extrapolate beyond needing to go to the ER or be hospitalized. If these patients are filling prescriptions rather than trying to finance a daily fix with illicit use, I think we can project decrease in utilization in other sectors as well. And this analysis, also done in Oregon, same population, same time frame in 2018, they looked at the combination of medication when offered in conjunction and coordination with what we call wraparound services. In this instance, we're looking at unsheltered population, chronically homeless populations who have substance use disorder. When they were given MAT and they were also given supportive housing, which is longer term, different from the short-term shelter use, they saw drastic reductions in the number of ER visits, 5,000 fewer. And this is, just to give you a baseline or a denominator, we're talking about 900 individuals in the Portland area who were identified as high utilizers in different systems. So of those, just placing those 900 on medication plus supportive services, 5,000 fewer ER visits, 400 fewer jail bookings, and better health, better utilization, better outcomes for psychiatric stays, a lot of these dual diagnosis, mental health and substance use, and over 200 fewer populations, or 200 fewer hospitalizations. This slide starts to get a little bit technical, but I wanted to include it to show the additional effects, benefits beyond just patients who are maintained on medication. And I guess I can simplify it by saying if a patient comes into the ER and I start them on buprenorphine on this medication, and let's say they run out of their prescription, they're not able to follow up, and they stop taking the medication, return to use, that patient is safer from overdose than a patient who has never started on the medication in the first place. And that protection is durable, at least up to 4 weeks, as measured in this graph. And that has to do with the brain chemistry, the stabilizing effect of the medication, decreasing the risk of overdose. Those numbers on the far left of the graph, the buprenorphine group, you can see the lowest blue bar are patients maintained who are taking their medication every day. And the green bar next to it on the far left are patients who were started on medication but then relapsed, returned to use for any number of reasons. Their rate of overdose was lower than the bar on the far right, which are patients who had never started on treatment in the first place. So there's a residual durable protection to this medication beyond when they're actively using it. This graph represents a number needed to treat, which is, again, a bit technical, but we use it in the clinical setting, this metric, a measure of how effective a medication is. So number needed to treat is loosely defined as how many patients need to be given a medication in order to avoid a bad outcome. Sometimes that outcome is death, sometimes that outcome is disability, but you can see that for buprenorphine, the very bottom number, the very bottom list, or row rather, for every 2 patients started on a high dose of buprenorphine, or every other patient started at that dose is maintained in treatment 6 months and beyond. To compare that number needed to treat to, say, defibrillators for cardiac arrest, that number is about 1 in 2.5. Aspirin for a massive heart attack, that number is 1 in 40. So this medication is one of the most effective interventions that we have in the medical setting. Another technical slide, but this helps clinicians understand in the setting of near universal fentanyl, synthetic fentanyl on the streets nowadays, our practice is changing, in the process of changing now, to adjust for these more drastic effects on the brain and the symptoms that patients have. So looking at that diagram on the right, if the blue squares are the opioid receptors in the brain, this is where our endorphins interact, our natural hormones interact, but also these opioids, synthetic opioids, also interact. The blue squares are the receptors, the red circles are the fentanyl molecules, and the green circles are the buprenorphine molecules. Again, to think about effects on the brain, let's say if we're opioid naive, never seen this synthetic artificial drug, then we might have, let's say, 100 opioid receptors, just for a basis of comparison. If someone then takes synthetic opioids and develops dependence and tolerance, the number of receptors increases significantly. So you go from maybe 100 to, let's say, 500. And that need, that dependence on increasing more and more amounts of the synthetic opioid is part of what drives the disease. The benefit of a medication like buprenorphine is it stabilizes those receptors and it prevents the withdrawal syndrome that all these patients are trying to escape on a daily basis. I mean, 1 to 2 weeks into someone's habit and addiction, it becomes a matter of not trying to get high, they're just trying to feel barely normal. That increases from pills to smoking to try and get more of an effect, to injection to try and get more of an effect, to looking for some of these augmented combined drugs like xylazine and what's called trank dope. And we believe we're starting to see in Minneapolis. It's a much bigger problem on the East Coast, but we're anticipating seeing more of this problem locally. What I want to say is, on this slide, it also speaks to the complexity, the clinical complexity of starting someone on medication. It's unlike most other prescriptions. It's not like an antibiotic you just go fill and take it home, later in the night. The patient needs to be in at least a moderate amount of withdrawal or severe withdrawal before they're ready to start the medication. If they are in only mild withdrawal, or if they maybe took the fentanyl a couple hours ago and they haven't shown signs of that withdrawal syndrome yet, then there's a risk that patient might feel a lot worse. It's explainable through the pharmacology, but if someone is taken from a relatively saturated state with a fentanyl to dropped very quickly to a rather normal state of stabilization, that's perceived as what we call precipitate withdrawal. And that is a huge barrier for patients because they want to avoid or they need some assurances that they're not going to be dropped into this, what may be side effect or complication of the medication if it's delivered either too early or at too low a dose. So that's a lot of technical language, but this is I would say, a universal barrier. Many patients, if not all patients that I talked to about starting this medication, their number one concern is avoiding this precipitate withdrawal. And that's also true for docs and prescribers, because they don't want to necessarily see their patient get worse either. So there's a barrier. If there's hesitation on the patient side, there's going to be a lot of hesitation on the provider side as well. As we evolve our practice, we have a much better understanding of how to do this safely and effectively, but that is a slow-going process. Myself, I've only started adjusting my practice within the last year and a half or so, just because I've been really paying attention to this data and these mechanisms. Broadly speaking, medication first is so intuitive. If we think about, say, a diabetic who comes into the hospital, they have high blood sugar, they might have a diabetic coma. These patients all get medications they need right then and there. And then if it's like, say, a new diagnosis, then they might be offered education or referral to follow-up clinics, how to manage their new diagnosis. Seizure disorder, same thing, another brain disease. We give the medication right away. We don't let people, seize on the streets or in the waiting room. Unfortunately, due to quite a number of reasons, opioid use disorder is probably one of the few examples I can think of where that's inverted, and the medication is offered for most patients after many days, sometimes a week or more. And that's because just the way our system has evolved, patients need to, fill out paperwork if they're uninsured. They need to go through a lengthy assessment process, intake, to, decide what level of care they need and what type of medications they would benefit from. They need to find availability in terms of appointments in the clinic or beds available in a treatment center. If they show up on a Friday and the prescriber isn't there, until Monday, that's another couple of days. But these are the types of barriers that are just prohibitive for someone who's dealing with intense withdrawal syndrome that's really a matter of hours, if not a couple of days, before that becomes overwhelming. And however motivated or supported they are, if their brain chemistry is not stabilized, it's highly unlikely that patient's going to be able to follow up with a plan if that's delayed by days or even weeks. So that's a long preface to this medication first model, which was first established in Missouri in 2019, to give you an idea how recent some of these evolving practices are. But in Missouri, they were able to show that same-day rapid access to medication, like you would, a diabetic would get that same-day rapid access. If you offer that to patients with opioid use disorder, then their outcomes improve. If it's same-day rapid access, they're more than 2 times as likely to be maintained in long-term recovery, even 6 months or more. So the timing of that stabilization has bearing on how well they do they turn the corner or not. This is now recognized as a best practice. The FDA, SAMHSA, which is kind of like the CDC for mental health and addiction, in terms of federal level, guidance and policy recommenders. They all recommend this. They just put out a policy guidance letter a couple months ago, re-emphasizing the importance of this. And that policy guidance is highlighted in the reference below. This is a portable treatment philosophy, so this can be done in ERs and hospitals. This can be done in community settings, offering that medication. If people are comfortable giving it, knowing the timing and the dosing, there's no reason this can't be done at home or in a drop-in clinic. But those logistics are a lot more complicated than what I just laid out. The one helpful example that we've been paying close attention to is this California Bridge model. Statewide in California, they've been able to incorporate that medication first philosophy in ERs and hospitals, just because we see such a large volume of folks cycling in and out, probably more so than any other place in the health system. They're able to incorporate that medication first and then supplement it with psychosocial support with what they call a substance use navigator. That's someone who can provide what we call accompaniment at the bedside while folks are struggling with these horrible withdrawal syndromes. And then they can also provide some basic care coordination. Once a patient gets the medication and gets that brain stabilization, they then need to be referred, they then need to find that second step in their journey towards treatment, stabilization, long-term recovery. And having that all as a package when the patient needs it most and they're ready and they're willing is very successful, and we've been able to benefit from some of the data they've just recently released, again, in the last couple of months. But it turns out if you do that, not only the patients do better, but the hospitals have better outcomes as well, because you have decreased return visits, and the patients get better treatment outcomes. So it's really a win-win in that sense. These next couple of slides show some of the data reported from that California model. And I'll just draw attention to the last number, the return on investment. Hospitals see that when this model is implemented, there's on average, more than $17,000 in savings. This is things like unreimbursed care or crowding, hospital type of metrics. That level of savings for an investment of just less than $350, which pays for an average of 9 hours of engagement for these patients. So the model in California started, I think, 3-4 years ago. It was incentivized with maybe $40 million statewide, big state. They had a goal to have this model available in all of their hospitals across the state. They started with 8 hospitals, and they're now close to 300 hospitals in just 4 short years. So they're well on track to meet that goal, even beat it. Largely driven by some of these outcomes for, better outcomes for patients, value and return on investment. So it shows all of this essentially, I think most attributable to that medication, access to engagement with that medication, and then support with a psychosocial case management. These are the types of solutions and examples of best practices that we've been taking a close look at for close to a year and a half now. Similar improved outcomes with follow-ups, and this is all substance use disorder, so this would include things like methamphetamines or cocaine, which act differently on the brain, still heavily related to the dopamine levels, but different opioid, it's a different receptor, it's not an opioid, so the medication that we have for opioid use disorder doesn't work for some of these other substance use disorders. But even looking at that broader population of folks struggling with addiction, having the medication where appropriate and that navigator, that psychosocial support, that case management, showed improvements of 50% engaged in treatment with that navigator, 2 to 3 times more likely to be in treatment because of the navigator. So the more we observe and learn from these pilot programs, the more clear it becomes how important these medications are. Locally, we've started to adapt, informed by the Missouri model, the Oregon data, and the California successes. We've started to adapt for local implementation these best practices, and kind of really trying to accelerate our evolving practice of medication, a lot of provider education, a lot of community education in terms of raising awareness not only of the risks of fentanyl, one pill can kill nowadays. A lot of people don't necessarily have that level of awareness of the increased risks. And that's at the University of Minnesota Medical Center. We are talking to colleagues in other surrounding hospitals who are also very interested in looking at this and expanding into other areas. Yeah, I'll stop there on this slide unless there's any other questions. Okay. Another very important aspect of really treatment throughout, not only the induction, that medication, but the stabilization period and long-term recovery periods. This trauma-informed approach has been understood to be critically important, and this policy guidance from 2017 speaks to that. And I would say after 2020, with pandemics and uprisings and all this collective traumatic stress, I think it's even more important today than it was back then. And I think that also helps explain some of the disparities that we're seeing locally here in Minneapolis. This slide looks at not the absolute rates in population, but it looks at the differences between subgroups by geographic area. So the overall average, according to CDC data with across the country, there are disparities between subgroups. That's a known challenge that's seen in a lot of different diseases. COVID was particularly raised a lot of visibility around differences in outcomes. If you look at Minnesota and opioid use disorder, for example, Native Americans 10-1 compared to the white population. When I first started looking at this data a couple of years ago, it was 7-1 in Minnesota. I thought that was eye-popping, and then 2021 that goes up to 10-1. But if you look at the Minneapolis data, the highest contribution to the Minnesota state level disparities, these are the differences in the differences among subgroups, is coming from Minneapolis. And it's coming from, if I had to guess, coming from our largest concentration in South Minneapolis. The 30-to-1 disparity, comparison, and difference, this is the worst in the country. This is the highest difference in differences that I've ever seen. So I think it's important to understand that context. I think there's a lot of contributions to that. I can't speak for the community, obviously, but I hear people talk about things like generational trauma, things like poverty, discrimination, things like trust, things like bias layered on top of stigma. I think these are all contributions. And I wonder how much our South Minneapolis experience in the last few years is also helping contribute to this. My gut says it's quite a lot. So I think all the more important that we have this understanding of what trauma is, what traumatic stress is, and how that applies to health outcomes. Trauma means different things for different folks. For some folks, it's physical trauma, broken bones, and car accidents, gunshots. But in this context, we're talking about traumatic stress and how it affects mental health and addiction. So SAMHSA, again, the kind of gold standard in terms of definitions here, they define individual trauma as resulting from an event or a series of events or a set of circumstances that is experienced by an individual or perhaps a community as physically or emotionally harmful or life-threatening, and that has lasting adverse effects on the individual's functioning mental, physical, social, emotional, spiritual well-being. I think something like PTSD in our combat veterans is something that's been understood for the longest period of time. We've seen mental health and addiction in that population. It's been well studied. More recently, in the 90s, people started looking at adverse childhood events and the long-term health impacts that can have. More recently, we are looking at chronic exposures in adulthood, and this is where I think the poverty and discrimination come into play. This is where I think we all have a better understanding of collective traumatic stress now with the pandemic. But the importance here is that that has a direct bearing on mental health and addiction. Behavioral health in this slide is a bit of an outdated term when we're talking about people's levels of depression, anxiety, people's dependence on substances can become more pronounced, or people are more at risk for that. If we remember the effects on the brain, this is initially those pills provide instant relief. If someone has a lived experience of trauma and stress, that pill, I can understand why someone would be prone to reach for that. They can be single or multiple exposures. Something like a devastating hurricane can be traumatic stress. And I've talked about some of the other examples. Re-traumatization is also known to, this is something that's cumulative, and the more exposures, the more often someone's re-traumatized. If you think of a combat vet hearing like a car exhaust backfiring or something like that, each time there's a re-traumatizing exposure, this effect gets more pronounced. The extent to which that's affecting our communities and our health outcomes, I think is a broader discussion, but something important to keep in mind that certainly beyond the scope of my expertise. There's a number of thought leaders in the field of trauma studies. Dr. Sandra Bloom is one. She's based out of Philadelphia. She came up with this framework of a public health approach to trauma-informed care that I think is really useful, and we're trying to incorporate in some of our planning locally. But she talks about a trauma-informed approach as basic knowledge and awareness that these relationships exist, and that they can affect health outcomes, especially addiction and mental health. As a hospital, if we want to be trauma-informed, it's not like everybody needs to have a very comprehensive definition, but we would want someone like, say, our registration clerk to understand that, people who've had traumatic experiences may be at higher risk for the health outcomes. Trauma-responsive care can be thought of as more like secondary prevention. And here, populations with exposure to trauma being at risk for additional problems, especially if you start talking about cycles of re-traumatization and whatnot. And there are policies and guidelines that can be incorporated, that can be developed as this is better understood. And then there's trauma-specific treatment, which really depends on the type of traumatic exposure that someone has. If you think of the effects on the brain of trauma, this is a really unpleasant, perhaps life-threatening experience that people don't necessarily, they kind of go into fight or flight mode, and they don't necessarily think through in a mental or in the mental model is more primal and hormone-driven rather than kind of more complex rational thought. And I say that because experts who talk about trauma, talk about it, these are, if we don't have a good mental model on this, then it's just kind of fragments of experience in the brain. And if we don't put a finger on it, understanding what's causing this distress, this chronic depression and anxiety, then there's this analogy out there that's like a splinter in the psyche. If that can be identified and labeled with words attached to it, then we can move people away from a more visceral fight or flight survival mode type of response to having more of a conversation about what's driving that and how can we help people with this. So these are frameworks that are still evolving. There's different opinions. There's a lot, especially more recently. A lot of different explanations and meanings for that, but I think it has an important role to play, especially with this public health crisis. Thank you.
Thank you. And I see that Vice Chair Payne has some questions.
Thank you, Chair Vita. Thank you for starting the presentation with just grounding us in the legislative directive, and I just wanted to share additional context around that. We wanted to be very explicit about medication-assisted therapy, but one of the things that were implicit in it was an exploration around safe use sites. And, the legal landscape is evolving, but right now there is a degree of clarity. But one thing that I'm trying to connect is it's really helpful to get to ground ourselves in the science and the biology of it. And then I'm just reflecting on the time that I've spent at the encampments in my ward and just the reality on the ground of what this disease looks like. And I'm trying to imagine that point of intervention so it's pretty clear to me that buprenorphine is a very effective medication. What's not clear to me is how do we cross that threshold into somebody choosing that path. In my mind, a safe injection site is a more controlled setting to be able to nudge people towards that path. In the absence of that type of strategy, and with this new knowledge around the importance of the stage of withdrawal that somebody needs to be in to start that, how are we imagining this intervention happening on the ground in the real world?
Chair Vita, Councilmember Payne, members of the committee, I think that's a really great question. One thing that we are working on is providing opportunities to address that gap in continuity of care. So when you're leaving the the ED or when you are ready to be medically inducted into medication-assisted treatment. Oftentimes, there's a gap where you're recovering from that withdrawal, and you can't really be in a place where there's not access to a provider that can help with adjustments to your medications or whatever other services you might need to deal with that withdrawal. One thing that we are working on is a partnership for a facility that would provide minimal amount of overnight stays. We need to start small, obviously, because we have to figure out how to target our resources, and so we're kind of trying things out. And so it would provide a space for folks who are coming out of the ED. They've been medically inducted into treatment, but they really are housing unstable. And so we want to make sure that they have a place, at least for a few days, where they can have some respite from the stressors of, every day where they're out trying to figure out where they're going to sleep or where they're going to get their next meal, and add that into just the medical piece of it where they're being supervised and watched. So, withdrawal can be very dangerous. And so we want to make sure that whatever we're doing to get people off of these substances isn't contributing to other negative outcomes medically. So that's one way. We're also looking at other treatment centers that want to provide this type of service. We have had some instances where we've had to look a little bit closer at our zoning and land use code, and so we've worked with CPED on trying to figure out how that enters into the picture. There's lots of considerations around where these spaces will be. And in what neighborhoods, and whether or not we want to concentrate them in certain neighborhoods. That's always something where it's like, do you really want that concentration? But also, you have concentrations in neighborhoods of this problem, and so you also want to have proximity with these facilities to where the actual hotspots are. So I wanted to continue just to wrap up really quick, if I may, and this kind of goes to some of your questions. Some of our key points for our future work is incentivizing this medication-assisted treatment expansion, which is what I was just talking about, is being able to have some of these creative partnerships with some of the communities that we see are disproportionately impacted, like Red Lake. We've been partnering to try and get a facility up and running, which I hope we're near to do. And also just like leveraging some of our funding. So we need to put some of the resources that we have into these facilities. So leveraging our settlement funds is one way that we can do that. Leveraging other sources of funding, such as grants, which we've been doing and will continue to do. And then just to provide a little bit of context and background around the city's general fund budget and the opioid investment that we have there. In 2019, which is kind of when we started, that's when the opioid task force that the mayor put together came out with their recommendations. There was $50,000 one time for a coordinator of those task force and the subgroups that went into that. In 2020, there was a $105,000 ongoing funding, and that went to hire our opioid response coordinator. And then $300,000 one time, which at that time went to our syringe litter cleanup. We didn't have any mechanism for cleaning up syringes or addressing that, so that's where we started our efforts around that. And then in 2021, we had $50,000 for one time, and that actually went to the fire department for safe stations. They had other funding that they were able to use for that, so that came back to us, and we used it for Narcan. At that time, we had a real need for that, and we still do, but we were able to use that $50,000 for that. And then in 2022, we had $100,000 ongoing funding for a community hub, which is kind of what we're using for the facility that we're working with Red Lake on. And then also, we've got a team of 3 And part of that funding also goes to supplement those staff salaries because they're mostly grant funded, other than that $105,000 that we got a few years ago. So our total general fund investment is currently $205,000, which supplements salaries paid by grant funds, the Red Lake Partnership, for example, like a public health nurse at the facility that we're looking at. And then, of course, we have the settlement funding, which is I would say it's very prescriptive, but it's also pretty flexible as long as we're making sure that the funding is going toward mitigation of opioids. The sticking point with that is it pays for only 10% administration. And so anytime we're increasing the number of programming and initiatives, we need staff to be able to run those programs. We cannot use settlement money for that beyond the 10%. So council was gracious to grant us $150,000 of the settlement funding to be able to hire a public health specialist for specifically the settlement money and implementation of this programming. And the 10% is kind of a moving target just because we continue to get the funding on a rolling basis. So it's a 10 to 18 year payout. And so the 10% is cumulative, so again, we don't know exactly how much that's going to be, but we have an estimate, so we know kind of where our lower gap is, or our minimum amount of the 10% would be. So I wanted to just kind of help folks understand where we are in terms of investment, and obviously, even with the millions of dollars that we're getting from the settlement fund, the need really does outpace the resources that we have. And then the second thing, prioritization and development and implementation of trauma-informed approaches to care in treatment and long-term recovery. I won't go into this a lot because Dr. D really did a good job in describing why a trauma-informed approach is so imperative in this work. And then emphasis on community co-design. He didn't talk a lot about this, but effective and equitable co-design is not a tool, but it's a way of collaborating directly with the communities that are being affected, often disproportionately by these issues. And so instead of outlining prescriptive steps, we want community to co-design with the intention of unleashing that untapped creativity and capacity within the community members that are navigating, whether or not they choose to, this complex issue on their own. And so I wanted to just talk a little bit about what those considerations were for future work. And then next steps really are just continuing to develop that long-term strategy around the opioid settlement funding, leveraging all of the sources because we'll get the direct allocation. The state also gets an allocation, which will then, some of that money will be opened up to other cities to apply for. Hennepin County is the same. They get a direct allocation. I believe it's around $40 million, and we're getting around 10-ish. Again, it keeps moving. And so just leveraging that and those partnerships to make sure that the region is able to maximize the resources. One of the things that we've talked about with Dr. D is the way that the settlement is set up really is not, it leaves it up to the cities to target our resources. Again, the need outpaces the resources that we have. And so what we need to do is make sure we're targeting the groups and communities that are most disproportionately impacted. And the settlement doesn't do that. It's based on population and census numbers, not where the hotspots and where the most need is. So it's our job to do that, and that's what we plan to do with the settlement money, but then also with all of the other existing resources that we plan to leverage. So with that, I will open it up for additional questions for me, the team, Dr. D. Thank you.
Thank you.
Thank you. Another question I had was related to part of the discussion from 2 weeks ago where we talked about the impact of naloxone, it kind of putting you into an instant and almost aggressive withdrawal. And I'm wondering, with this kind of new information around the sensitivities around buprenorphine treatment, what does the timing look like in the immediate aftermath of an OD that was recovered with naloxone? Is that a setting, like a clinical setting, where it would be appropriate to start that treatment right then and there, or is it a really challenging timing thing to figure out?
Chair Vita, Councilmember Payne, and members of the committee, that's a really good question. I'm going to turn it over in just a bit to Dr. D so that he can give some more information on that. One thing I think that he'll talk about is trying to initiate that medical induction through the paramedics when they're on site at an OD. Right now, it's basically done in the emergency department or with your provider. But looking at creative solutions to that is exactly what Dr. D and other folks are doing. So I'll just invite him up to maybe say a couple more things on that.
Chair and member, thank you for the question. Yes, we are, like I say, it's an evolving practice. We are doing this more often in the emergency rooms. I've done it myself several times. The paramedics are starting to carry this in the ambulances so that it can be offered on the scene. It's really the best time to start somebody on buprenorphine because you don't have to worry about, how mild or moderate or severe your symptoms. We know they're in severe withdrawal, and we know they'll feel better within 30 minutes, feel better, and then probably normal again within a couple of hours. That's a very compelling case for this opportunity. There's complications because, not everyone who's resuscitated, they might have something else going on. They might have some xylazine on board or some other, what we call respiratory depressants. And in that case, we're just not certain the data support a high dose of buprenorphine. One of the great things about that medication is there's a ceiling effect where the effect of, one of the problems with fentanyl is people stop breathing, one of the side effects, and that precedes death. Buprenorphine is unique in that it doesn't have that side effect to dangerous levels. So I can be very confident giving someone high doses of this medication and not have to worry about that side effect. But if they have alcohol on board or they have Xanax on board or they have something else that might also suppress, then I have a lot less confidence that there's no risks to this medication. So there are, in some cases, it's a perfect opportunity. If the patient they also need to agree to this, right? And that can be, a couple of seconds of advice, and this will help you, or that might be a couple of hours before someone is ready. So yes, that is happening more and more, but part of the challenge is figuring out, okay, who do we avoid? Methadone, for example, because of the way the pharmacology of that drug works, that's an exclusion criteria for this type of intervention. So there's details that are being worked out, but we're getting better at this, and I think moving forward, that's going to be a key intervention.
And then that raised my last question, which is barriers to prescribing this. And I was curious specifically as it compares to methadone. And I don't know the difference between the two. I just kind of have this loose understanding that you're basically replacing one opioid for another one that's less dangerous. Is that the same kind of biology here with?
I would say, Chair, member, thank you. I would say, I think of it more as hormone replacement. If we talk about a diabetic who has a pancreas that's not making insulin, we give them the hormone that they need to stabilize and lead a normal life. In opioid use disorder, these are patients, because of those changes in brain chemistry, they're no longer producing dopamine and endorphin that we depend on. We can't live without it. So I see buprenorphine and methadone, for that matter, as really more hormone replacement in terms of stabilizing the effect. There are important differences. Methadone, for example, it's still highly regulated, so patients need to show up on a daily basis. An important difference with buprenorphine is we can now prescribe, like a 2-week supply, a month supply, So we avoid that because it's considered a safer drug. I think we have agreement on that. You're not at risk of overdosing on the buprenorphine, whereas someone, because methadone doesn't have that ceiling effect I talked about, there is a risk of overdosing on methadone. So that's part of the difference, a very important difference in the regulatory burden. That was lifted on buprenorphine, that regulation was lifted on buprenorphine just a few months ago, January of this year. So we now have a much broader pool of doctors who are able to prescribe this. The challenge there is with fentanyl changing the chemistry and the dosing. It's a different disease now than it was 5 years ago, 10 years ago. So those are the types of challenges. Those are solvable problems, but that's why not everyone's writing for this prescription at every opportunity.
Thank you.
Thank you. Councilmember Rainville.
Thank you, Madam Chair. Dr. D, thanks for coming back here. You are a rock star, so thank you for your advice. This will be so helpful as we move forward. And I just want to say it a different way than Councilmember Payne did. It seems like we have to have this intervention, whether it's voluntary or mandatory, and then have navigators helping keep that person going. So again, your thoughts on the two, the voluntary versus the mandatory intervention?
Chair Member, thank you for the question. My opinion, my practice, it's essential that this is voluntary, and the reason is if it became mandatory, if there's a risk of mandatory induction, there are 1% of the time there is this bad outcome of precipitated withdrawal. That can be managed. We know how to do that with increasing confidence. But it's not a harmless intervention. Sometimes we may add immediate harm. That can be, we have medications and a game plan to deal with that. But I think more importantly, if people avoid coming to the ER or avoid calling the paramedics because they might be subject to something mandatory, then that's an additional barrier to treatment. As compared to, say, if we're doing community-wide education, which we are now, and enlisting the help of trusted groups and leadership in the community, we can increase demand or increase interest in this medication at the same time that we're also better preparing ourselves as a health system to deliver it, that rapid access to medication. That's my thought on that.
Thank you.
Thank you, Councilmember Rainville. Councilmember Wansley.
Thank you, Chair Vita. First, thank you so much for this fantastic presentation. I want to acknowledge that it was very thoroughly done and really helps us as policymakers kind of orient better to this topic so we can make informed decisions. And you also very much clearly presented around a problem that we do have the ability to solve and have a variety of tools to get at the root causes of why folks gravitate to some of the substances that you highlight in this presentation. But I just had a couple questions in regards to the state funding that's coming through. I know it seems like there are some restrictions with the opioid settlement funds, but are we anticipating, applying for some of the state grants that is going to be rolled out in the coming weeks based off of some of the work that our state lawmakers did around, opioid overdose prevention and things of that nature?
Chair Vita, Councilmember Wansley, members of the committee, thank you for the question. I anticipate that we're going to apply for any money that we're eligible for. Again, I'll just reiterate the demand outpaces, the need outpaces the resources that we have. In fact, I think it's later on tomorrow afternoon, we've got a local public health group that gets together to talk about what each local public health unit is doing with their settlement money. Hennepin County also convenes a group of the cities within the county to talk about what they're doing, and then ways that we can partner, and also just ways that we can leverage that funding. I'm not exactly sure what the state or what the county plan to do. They could very well come out and say, we're going to provide this funding to every city except Minneapolis, just given the fact that we've got a larger chunk of money. Hopefully they don't do that, knock on wood, but that's certainly a possibility. But again, back to the initial answer to the question, we are going to seek any funding that we are eligible for.
And follow-up question, it's really good to see our health department lead on this, especially with the emphasis of utilizing a public health approach in this work. I'm interested to know, as you're working out this comprehensive, opioid response plan, are there other departments within OPS or even OCS that you'll all be collaborating with?
Yes, Chair Vita, Councilmember Wansley, and members of the committee. Actually, we've been working with a number of different departments pretty much since we knew what when we could expect the settlement payments and how much. We took an inventory of all of the existing direct and indirect costs around opioids from all the different departments. Every department, for the most part, was very cooperative and helped us put that together. So, we've got a finance working group, we've got an engagement working group, and we have a programming working group. And each of those have multiple people from various departments, from the Office of Community Safety. So we've got MVP, we've got the Department of Neighborhood Safety, we've got MPD, we've got fire, and then we've got CPED, we have finance, we have NCR is a big part, not just for what they might spend or use in and of themselves, but also their ability to help us reach the folks out in community. They've got a wealth of resources, of staff capacity and resources within NCR to help us with this work. And I'm trying to think if I'm missing any other department. Race equity, inclusion and belonging has been a part of it. I don't know if I'm missing any, but yes, to answer your question, we have been working with them.
Awesome. And when can you anticipate giving either this committee and the public a presentation on item 1 in terms of, long-term strategy, or even item 2, the comprehensive plan, as follow-up next steps?
Chair Vita, Councilmember Wansley, and members of the committee, that's a hard question to answer. I think, part of it is going to come through with the budget, just like it did for 2023-24. So we saw $645,000 allocated. That was an estimate at the time as to how much we thought we might get. We have a little bit more than that right now. We had some accelerated payments come in. And so we're trying to make sure that we can bring you all a set of recommendations on strategies that are acceptable uses of the funds. And we want to do that sort of in as little times coming back in front of you as possible. So we want to have more of a comprehensive package, but there will be some one-off items will have to come forward because we can do some things faster than others. And so I would anticipate that before the end of the year, before the budget, there might be a couple things that come before you, but really I think the bulk of it is going to be wrapped up in this budget process.
Okay, I just want to recap that in terms of, I know typically we've been doing some of the one-off things, for instance, even with OCS, and I think a concern has consistently been of what is the comprehensive kind of plan that's guiding the work, so we can see how, we're threading the needle throughout all of these initiatives and working towards kind of a common goal. So I think it was more so of that, of I understand through the budget process, we'll have some of the individual strategies that might need to be approved, and definitely within the container of restrictions of funding, but that overall list of strategies, it would be good for this committee to get a sense of what those are. So as those individual items are coming to us, then we can say, oh, it's part of this or part of X strategy. So that's what I was really indicating, of that comprehensive package of the individual strategies in terms of when we can anticipate seeing something like that. That seems kind of separate from budget conversations or budget release in August.
Chair Vita, Councilmember Wansley, and members of the committee. I think in terms of the budget process, what we think will happen is we'll be talking about some of the strategies that we've taken guidance from the mayor's office. For example, in the 2023-24 budget, the 645 was specifically allocated towards evidence-based treatment as a strategy. And so I think we'll see those types of things come forward. So evidence-based treatment as a strategy, and maybe even more specific capital for treatment centers, that type of thing. But we'll get you, when we come through, rather than having like a specific, we want a treatment center right here, that's developed by this person and run by this person, it will be more of that high-level bucket. This is the strategy that we plan to employ. And then when we get down into the nitty-gritty, you'll be approving contracts, you'll be approving RFPs and things like that for when we do start to need to get that money out into community. And of course, this funding, even though we come to the council in order to draw down on the settlement funds, so we get the approval from council for that, we still have to follow all of our procurement processes. So contracting, RFPs, all of that stuff, we'll still have to follow that procedure when we're coming through.
Yeah, and just a point of clarification too, I mentioned earlier some of the state funds, which I know when you're applying for those state grants, they do want you to present a comprehensive plan. So it seems like, again, there's a bucket of work that's going to be structured around the opioid settlements, because again, some of those restrictive dynamics, and it seems like existing clauses, as you mentioned, from budget discussions prior to right now. But in terms of the state funding that is going to be addressing overdose preventions, they're going to want to see a plan around that work too. So that's why I'm mentioning of like, it would be good to have that comprehensive package of what's already in the works and how we're going to make ourselves competitive for some of those grants that's about to come down the pike, that our, statewide lawmakers advocated very diligently for. So I think it's that piece where I'm still not sensing like a collective plan or collective vision of this work versus, items happening in isolation of one another. And I think that is the ask in front of our public health department of what does it look like to have, even at the high level, all of this centralized in one place. So we're not just approving individual items and being like, wait, what is this connected to? So just wanted to provide that point of clarification too, of like, I get the opioid settlements, but we have the state funding too that's going to be helping shape some of the work that was presented in this presentation, and wanted to figure out how we're setting ourselves up to be successful competitors for those grants when they start being enacted. And it seems like that might not be clearly identified right now. And I hope it will be soon. In terms of, Doctor, I did have a follow-up question for you in terms of some of the demographic data points. I wanted to know in terms of demographic breakdowns for age groups. I know you did a really good, breakdown around racial dynamics of some of our disorder, or folks who typically are, dying from overdoses and things of that nature. But one thing that I hear repeatedly is a lot of our younger folks are increasingly dealing with substance use disorders too, and getting the sense of if there's any data analysis around that demographics too, to kind of back up, or again, around a comprehensive approach. Do we need to be looking at youth focused initiatives around some of the interventions that we're going to be leveraging as a city?
Chair Vita and Councilmember Wansley, members of the committee, I'll have Dr. D come up in just a second to answer that question. What I will say is, youth is definitely something that we're looking at, and I totally lost the question. Can you restate the question?
For youth, the youth breakdown, or the fact, or the sense of we don't have a plan?
Okay. What we do know, and I don't think we have a graph, I just looked at it, was that 24 to 34 is the highest incident of opioid overdose. And so, yes, that's definitely an area that we are targeting. And working with Metro Youth Diversion as one of our partners, also Generation Hope as one of our partners. So really making sure that we are targeting the youth as well as the Native and East African community and then the unsheltered population. Those are our 4 areas of high risk that we are looking at targeting. But Dr. D, you have anything to add?
And that would be good, again, in having some centralized document of like, that's great to know. Yes.
Yeah, we are working on that for sure.
Chair Member Wansley, I completely agree that focus on the youth is incredibly important, especially when it comes to prevention, education, how we talk about risk communication and health promotion. The unique aspect about the adolescent brain is if someone uses opioids, I think before the age of 25, and we're seeing a lot of 15-year-olds, we're seeing a lot of high school students experimenting, and they get the wrong pill, and then they're hooked. That early age of exposure increases your lifetime risk twofold compared to someone who maybe saw their first opioid pill at the age of 30, say. So I think all the more importance on prevention education in the youth. I would also add the treatment considerations are slightly different, but I think maybe that's a little more technical than certainly I understand. And if I'd also comment on competitiveness of Minneapolis for state level funding, I think that's hugely important. And if I could speak as a constituent in South Minneapolis, with the highest burden of disease in the country, really, if you're looking at those differences, the gap, that's a chasm. That's not our expected gap and differences amongst groups. If the state level funding is being allocated according to population numbers across the state, then that might actually have the effect of amplifying these disparities. I think a better approach would be focusing funding that's meant to remedy harm on the areas with the highest burden of disease, South Minneapolis in this case, rather than a more arbitrary kind of across the board population numbers based approach.
Thank you for offering that. I hope that's something that our deputy is also taking into account, and hopefully, comprising a more comprehensive strategy or sets of strategies that this body can look at that is both targeted, but also looking at where are we already seeing the demographic burden happening based off of what you just presented today. So thank you for highlighting that piece of what can set us up for being successful, again, for these grants at the state level. And then also last question on that piece, around the Navigator program at the University of Minnesota, the medical center. Can you share, how long has that been active for? And if there's been any data tracking around that too, or is it kind of early?
Chair Vita, Councilmember Wansley, members of the committee, going just back really quick to the question, Suzanne just texted me, let me know that we've got some state grants that we've got started working on for focus on our youth. And so when we come back and do a more comprehensive presentation of our opioid work, which we should have more details around a comprehensive plan for the opioid strategy, we will also have an update on that work as well. So obviously there's ongoing work besides what we're doing with the opioid settlement. We want to wrap that all in to one larger strategy. Even when we come forward with, one-offs, all of that will be wrapped in the comprehensive strategy. We just know that the need is real urgent right now. And so we want to move as quickly as we possibly can.
And you're mentioning that, making sure I'm recapping, that you're hoping that will come forward to this committee before the end of the year, or we're thinking closer to budget, like that full wraparound proposal?
Chair Vita, Councilmember Wansley, and members of the committee, we would definitely need to work with the chair on timing, just because, we don't want to be in a situation like we were maybe last time we were here, where we are, we're not able to finish whatever we're doing. So we want to make sure that the agenda has enough time to devote to it. So we'll work with the chair on when the best time to come forward with that is. And it might come forward really with the budget process as well. So we just don't know quite yet, because we're not that deep into the budget process with the mayor's office yet.
Awesome. Again, seeing comprehensive strategy that seems kind of somewhat interrelated, somewhat separate with the budget process. But I think the most important thing, this is listed as a next step. Just wanted to get a sense of a realistic timeline of when this body can see something. And it seems like that's still kind of fluid right now from the responses you've given. But if there is, in terms of the university program, is there any information on that piece?
Chair Member, thank you. So the answer to that question is, I would say we're in early prototyping phase. We have launched the Navigator program just in the last couple of months. Prior to that, we were doing a lot of provider education around these new prescribing practices. Again, that DEA regulation just lifted in January of this year, and we took advantage of that opportunity right away to provide this kind of continuing medical education on this topic. The hospital is part of a broader system that's also very interested in expanding, looking at some of the same data we talked about. So it makes sense in a number of ways. That can be incentivized to speed that up, for expansion beyond to other hospitals in the metro area. We're in some discussions around that.
No, I was just super excited to see this because University of Minnesota is also in my ward. So any way to amplify, the fact that they're using this navigator model that you talked about in your presentation, the ways in which we've seen reduction in all of these type of high-risk factors. As a result of that, I was just really excited to see that, the University of Minnesota was taking the initiative in launching one of those, pieces to really be responsive to this epidemic we're experiencing. So would love to follow up with you to learn more if they do site visits or any way to further amplify and see how they're carrying out such a crucial component of this work. So that's all.
Wonderful. You're most welcome anytime. Thank you.
Thank you.
Thank
That's
you.
all.
Thank you, Councilmember Wansley, and thank you, Dr. D. I just wanted to say thanks for the presentation again. I love to see that the element of treatment is in the work that you're doing. I'm a big fan of treatment. I know that a lot of issues that we talk about daily on this council with housing and jobs and so many other things come with treatment, like a long-term treatment for some folks, short-term. So I'm happy to see that that's a part of the plan, and I'm hoping that that's going to be a part of the plan for us here at the city on how we use our funding. We have a wonderful facility in Councilmember Ellison's ward that I've been working with. Turning Point has culturally specific treatment for African Americans, and I think they do a great job. They're right in the neighborhood. People trust them. So I would love to connect you with them. I think they have navigators there already, and we just don't call them navigators, right? Like they have people that are doing the work that you described, and how the connection of services are there. So my office is going to send you an email and connect you with some folks over at Turning Point, if that's okay with you.
Chair, please. Wonderful. Thank you so much.
Thank you so much. And thank you again, Deputy Chief Ritchie, for bringing this forward. We will coordinate for the additional information on the committee schedule. Thank you. Thank you all. And seeing no further discussions, I will direct the clerk to receive and file this presentation, this report. And seeing no further business before us, I will declare this meeting adjourned.